go ahead and get this on started. All right, so this week we're talking ENT. Stands for ears, nose, and throat. Used to be back in the day. The department was actually EENT, eyes, ears, nose, and throat. But then the eyes got to separate out to their own place because they have a lot more equipment and they need a lot more space. So now when you go, it's just the ENT doctor that you see. So what we're going to focus in on today mainly is the ear. We'll talk about the anatomy and the different ways that you can lose hearing or different issues that require surgery on the ear. First of all, there's the conductive hearing loss. Does anyone know what the word conductive means?
Electrical, right?
It does have something to do electricity-wise, but more in general of what the word conductive means. Because you can like have conductive heating, you can have like a conductor of electricity, other things. Generally, what it means is things have to be touching. So when we're talking about like conductive hearing loss, there's either a significant damage to the tympanic membrane or the eardrum, because the eardrum is connected to another piece in the middle ear, which is then connected to another piece. So any one of those pieces degrades, whether it be the eardrum itself or one of the ossicles, which we're going to get into on the next slide. If those start to degrade or something happens to those, that's where you get that conductive hearing loss. Because now you're not getting the right vibration and the right message being sent. It has to be, though, like damage to one of the physical structures. The sensorineural hearing loss is now there's damage to the nerve itself, to the auditory or vestibular cochlear nerve. There's a problem there, and then that requires a different kind of surgical approach in how we correct that form of hearing loss. So let's jump into the anatomy of the ear. So the ear itself is separated into three sections. Right? You have what you see on the outside, that's your external ear, and the external ear goes all the way up to the tympanic membrane. So it goes all the way down the ear canal. The outside of the ear that we see is called the pinna, or the auricle, or even like the external ear. So this is where we gather the sound, kind of like a radar dish. Some people have a bigger radar dish than others, but there is surgery also to help correct that as well. But you'll learn about that when we get into plastic surgery. But so that's going to gather that sound. That's the little waves you see here, the sound waves coming in, getting collected here. The sound then travels down the ear canal to the tympanic membrane. Then from the tympanic membrane to where the stapes meets the cochlea, that's the middle ear. The main structures you're going to find in the middle ear are your tympanic membrane or eardrum, and then the three ossicles. So these are the three smallest bones in the human body. And they're always in this order. You have the malleolus, the incus, and then the stapes. The way to kind of remember this order is you have the mallet, the anvil, and the stirrups. So the way that this goes is that the sound comes in through the external ear, that those sound waves then vibrate your tympanic membrane. They make it, kind of bounce back and forth. Well, the mallet, the malleus, is connected to the backside of that eardrum. So as it vibrates, it makes that mallet move, and it makes it tap on the anvil or the incus. And the tapping it does on that then vibrates and shakes the stapes or the stirrups, because it's shaped just like a stirrup that you would use to get onto a horse. And those stirrups are connected to the cochlea at the vestibule and the oval window. Then it sends those sound waves through the cochlea and through the little snail shell here. And as it's doing that, it's transitioning that sound from analog, what we hear in the real world, to like a digital signal so that it can send it down the nerve to the brain, and then the brain interprets what we've heard. So, and this nerve is the vestibular cochlear nerve or the acoustic nerve. It is cranial nerve number 8. It is cranial nerve number 8. What cranial nerve is it? Number
8.
Thank you. You may need to know that. That's why I said it 3 times. Number 8, 4 times. So that is the hearing part. So that when you say the name of that nerve, the 8th cranial nerve, vestibular cochlear nerve. The cochlear part of its name refers to hearing. The vestibular part refers to balance. And that's what these semicircular canals are for. There is a like an endolymphatic fluid. I just looked that up today. Thank you, Grube. That resides inside these canals, and it sits at a certain level. And as you turn your head and look down and look up, that level stays relatively the same. That's why you don't feel dizzy whenever you're looking around. Right? Whenever you spin in a circle, you don't feel dizzy while you're spinning, right? But as soon as you stop spinning is when you start to feel dizzy. It's because the fluid inside of those canals is still spinning when you physically stop. That's where you get that feeling of dizziness. So if there's too much fluid or too little fluid in those canals, that's where you get those symptoms of vertigo. Because if there's too little or too much, any slight movement throws that level off. It's got to be just right for each individual person. And those levels are going to change depending on that person's height and their structure and how they're like set up and things like that, because it is very specific to each individual person. So that is hearing. Here's the cochlea, and the semicircular canals take care of your balance. So that's why this is the vestibular cochlear nerve, and its function is for hearing and balance. That is the function of the ear, is for hearing and balance. So let's zoom in a little bit here. Here's that inner ear. So here's where that window, the oval window and the round window, this is where the stapes connect, and is sending that signal through the cochlea here. And then there's also a signal that lets them, and there's little cilia inside these semicircular canals with pressure and nerves and sensors and things that pick up that fluid balance. There's like a little lymph node that sits just off of here that has a duct that feeds these semicircular canals with getting rid of old lymph fluid and new lymph fluid coming in. You don't need to know the names of each of these like little sacs and all that kind of stuff. You just need to understand this kind of structure and what its function is. Right? You need to know the names of the semicircular canals, the cochlea, and what their functions are and what connects to them. Right? You need to know this nerve, especially what cranial nerve it is, and you need to know what's connecting to it in the front here and how a damage to that then can affect your hearing. So you can see back here in the middle ear, if there's like a degradation, a breakdown in the bone of the stapes, and it no longer connects to that oval window and round window, then you're not getting your message anymore to the cochlea, which means the nerve's not getting it. The brain has nothing to interpret. There are surgeries you can go in and do what's called a stapedectomy. You're going to remove the broken down pieces of that stape and then put a new implant in, a little plastic one that takes its place to bring back some of that hearing. But that's conductive hearing loss. And here would be like a sensorineural. Something's happened to the nerve or to the cochlea. And this would require a cochlear implant. And they would put a probe down in from the outside of your head. They would actually drill down through the mastoid bone and everything and put a probe right up here against the nerve. And then you have a little piece that sits on the outside of the skull. And then that connects to the hearing aid that the patient wears. So then the hearing aid is now picking up the sound and then delivering that message immediately to the nerve. So it's bypassing the external and middle and inner ear. You're no longer, all of this is basically now just for show for that patient, because it's the hearing aid that's acting as the external ear and acting also as the middle ear and the cochlea, because it's receiving the message, it's transferring it into that digital pattern, and then putting it directly onto the nerve for the brain to interpret. See? And that's how sound transmission occurs. Everything I just talked about, sound coming in, vibrating the eardrum, shaking the mallet, making it tap on the anvil, which then vibrates the stirrup, which gets that message into the cochlea where it can transmit it into a neural pattern or a digital signal, and then puts it onto the nerve, and it takes it to the brain for you to interpret. Seem easy enough? Everybody kind of understand that? So if you were asked something like that on a quiz or a pop quiz or something, that you might be able to track the transmission of sound through the ear. Excellent. So now we'll get into some diagnostics. We gotta figure out what's going on with the ear, right? This patient comes in complaining of pain or they can't hear out of one ear. We gotta check it out. So a few ways that we accomplish this. Let me zoom in a little bit there. You have the otoscope. That's what you see here on the left-hand side. Many of you have seen this in the doctor's office. They use this to look in your ear and also shine the light like into the back of your throat, right? So when looking through the otoscope, what they're looking at is your tympanic membrane or your eardrum. And these are some of the sites that they can see. So number one, this looks like this is a normal looking eardrum. Right? It's not clear. But then as you move along, because this is number one here, 2, 3, This one here is otitis media, which means an infection of the middle ear. One thing I didn't point out back here is this here. This is the eustachian tube. I know it says auditory tube here. That's another name for it, but the name you're going to see most often is eustachian tube. This connects to the nasal sinus, which is why whenever you have like a sinus infection or a cold and you're all congested in your sinuses, that it affects your hearing because it pushes that pressure and everything. And even if fluid doesn't get in here, you still have the air pressure being greater than it was. That's putting pressure against this tympanic membrane, and it doesn't vibrate as much as it did before because it now has pressure on the back side, which then makes your hearing sound like things are a little more deadened, right? Like everyone sounds like they're talking real muffled and low. This is also where a lot of children will get what's called swimmer's ear. A lot of the reason that it happens to kids more often than adults is the way that our anatomy is set up as children. This eustachian tube actually comes out more this way, sideways, rather than straight down. It's a little more flattened out, which allows for fluid to get up in here, but then can get it trapped in here. And then that fluid being trapped in there, and I've said this before, what happens to any fluid that pools in the body? With blood, you're going to get coagulation. But any other fluid that's pooling in the body that's not supposed to be there, typically will bring with it an infection. You're creating a nice environment. It's warm in here, right? It's dark. And then with fluid, you add fluid into here, just sitting kind of pooling fluid, and you've made a perfect environment for bacteria. And because this is connected to the nasal passage, and there's some kind of cold or stuffiness or something maybe going on, there is bacteria that can get in here and then grow in that space. And that's where that leads to these infections, right? So an infection of the middle ear, not really like a seroma. That it's just you're filling that cavity with fluid, and it could be serious fluid, but a seroma is more like an encapsulated. It's going to have tissue like that turns it into kind of like a balloon. And then you have like the fluid inside of that. But this is like a clear fluid, like more like a swimmer's ear. Number 2 is where you've been out swimming, water's gotten up in there, and it's gotten trapped in there, and then infection starts to happen. The third one here, this is more of a mucosal type infection. This is where you've had a cold or you've had a sinus infection or something like that, and some of that fluid has gotten up back behind the eardrum. Number 4 here, this is chronic infection, right? You had the infection, it went away, it came back, it went away, it came back. Or you've had that same infection for a long time, but also the eardrum has perforated, which means it's popped a hole in it. From what I understand, rupturing your eardrum is an excruciating pain, almost comparable, they say, to childbirth. Typically, like if you get a cut, or yes, thank you, Allison. So somebody who has experienced a ruptured eardrum, there's nothing that, like, if you get hurt somewhere or something like that, you can kind of hold it. Like, if you hurt your shoulder or something like that, there's usually like a position you can put it in that makes it start to feel a little bit better. I mean, it still hurts, but it's not this constant, just excruciating pain. With your eardrum, you can't put pressure or anything. There's nothing for you to hold, or you just have to and hope like nobody comes over and talks to you. because you no longer have the eardrum is kind of also like a protective thing for the sound coming in. So now you don't have a protectant for the sound, and everything's like super loud and it, ridiculous pain is from what I hear. Then you have like acute infections. You can even start to kind of like make a stone in your ear. It can even start to get sclerotic and harden. That's what's going on here, is that it's almost like a cataract of your eardrum. You can have a traumatic perforation like this. This could be a Q-tip. You put it in too deep, and I mean, I'm sure some of you have accidentally, I've done it, accidentally gone too deep with the Q-tip, and you're like, oh, now imagine perforating that eardrum. It's even the scale shoots way up. And then number 9, this is a blockage. It says of cerumen. What's cerumen?
Earwax.
Earwax. Right. That's not, and this could be also from Q-tips as well, because Q-tips, when you put in the Q-tip, that cotton thing is just as big as your ear canal, and you can kind of twist it and get some of the stuff off the like sides and stuff. But when you first push it in, you're just acting like a plunger and pushing whatever loose earwax back in up against the eardrum. So over time, you're just building like this cake layer over the eardrum, and that could be another reason why hearing degrades. And some people, they'll go into their ENT office, and the doctor will perform like a washout with a lavage, that's what they call it, and wash all the earwax out of the ear. And patients walk out of the office like, wow, like I can hear so well. Like, I haven't been able to hear this good in a long time. But they can also use this otoscope, to look in the back of your throat, check out your tonsils, your uvula. Does anyone know what the uvula is? No. No. The uvula is the hangy ball in the back of your throat that you can do. It's like the speed bag in boxing. There is a procedure to remove that. We'll get into that in a few slides. But typically they'll take like that popsicle stick, tongue blade, and make you say, ah, right? Open up and say, ah, stick your tongue out. And they're pushing your tongue back or pushing your tongue down so they can see into the back of your throat, into that pharynx, larynx area, looking at the tonsils. Right? And then, of course, CT scans, MRIs of the head and stuff like that, of the sinus cavities, include them into some things that are going on, either nasally or even explain some issues that are going on in the ear. If they see evidence of like chronic or acute affections of the sinus, it may lead to what's going on in the ear. So things to think about. Right? We're working on the face, right? And specifically the ear, but positioning. Most positioning of ENT patients is done in the supine position. Even if we're working on the ear, we'll just turn the patient's head to one side or the other. While working on the ears, the nose is right there in front, mouth is there in front. So pretty much for ENT cases, the patients are supine. Even if we're working, doing like a thyroid or something, we just kind of extend the head back a little bit. Everything done in the supine position. For draping, some procedures in ENT, we'll talk about prepping first, I'm sorry. Some procedures in ENT don't require a prep. If you're doing like ear tubes, tonsillectomies, things like that, because we're working inside of somewhere, so there's no real prep to do, and some of these areas are considered to be dirty areas already. So there may be very minimal draping. But with that said, when working on like the nose, doing like septoplasties, when working in the mouth, things like that, we may put on a head drape on the patient. I will definitely show you guys this in lab. You'll get to see it. But what you need is a 3/4 sheet and 2 towels. And the way you'll set it up is you'll put the 3/4 sheet down and then the 2 towels on top of it. You'll hand the surgeon all 3 together. The nurse is going to come over, or anesthesia, and they're going to lift the patient's head. Now, because we need to go underneath, we're coming in from above, we need to go underneath the patient's head. You can't grab the head by like the back of the head and pick it up, because now the arms, that person's arm is going to be in the way for us trying to drape. So typically what they'll do is they're going to grab the patient's head on either side and just kind of tilt it up. And then we're going to slide those drapes underneath, and then they're going to lay the head back down. The 3/4 sheet stays down, and that first towel stays down. And then the very towel that's actually touching the patient, we're going to wrap that around the patient's head, like wrapping a towel around your head after getting out of the shower, right? And like have a turban style. And then we may use a perforating towel clip right at the forehead to help hold those towels together. We have to make sure, though, that we don't accidentally clip the patient when clipping those towels. So they kind of like pull it up away from the forehead a little bit, make sure they've only got towel in the clip, and then clip it and then let it stay. And that'll keep the towel wrapped around, it keeps all the hair from getting in the field. Because even the hair is even dirtier than where we would be working. So in surgical terms, anyway. Not saying that anyone's hair is dirty, but unless you've got, like you're a 33-year-old white male with dreadlocks that you've had for 13 years, then your hair might be a little dirty. A little bit. Irrigation is just saline. Typically, what we want, the key about the irrigation is that when you're working in the mouth, they may put a moistened Raytec. You would take a Raytec from your field, dip it in your saline and wring it out, and then open it all the way up. And they're going to take that Raytec and shove it into the mouth, down into the back of the throat. Not like down the esophagus or anything like that, but just in the back of the throat to help cover over the esophagus and the trachea and stuff, so that no fluid goes down into those and then aspirates and gets into the lungs or something like that, causing like a pneumonia. For some of the micro surgical cases, there's a specific kind of speculum that will go into the mouth and kind of down the throat. And there's a holder that goes for that kind of puts some leverage on your Mayo stand. I think I have one in the lab that I can show you guys. Yeah, I think it's in the microlaryngoscopy tray. I'll pull that out this week too, so you guys can see those instruments. But the reason for that holder and the leverage it puts on it is it really kind of pushes the mandible kind of forward a lot, so that they can get down and work on like the vocal cords and things like that inside the larynx. But here's an example of that head drape on the left-hand side here. I can figure this computer, there we go. So this is the 3/4 sheet down here, and then they're wrapping the towel around, and they'll incorporate the ear too. And this is if you're just working on like the nose or the mouth. If you're working on the ear, then they modify the drape so they have access to the ear and behind the ear. Because anytime you're working in the middle or inner ear, you have to access that through the mastoid bone behind the ear. The only time we're going down the ear canal and working is if we're just doing those ear tubes on the eardrum. Anything else inside the middle ear or inner, we have to access through what's called a post-auricular incision. So post meaning behind, auricular being the auricle or the pinna, the external ear here. So that's post-auricular incision behind the ear. As far as if we do prep, because like if you're making this incision, like you are going to have to prep out this ear here. It's usually with betadine. You don't want to use any like alcohol stuff in this area around the face and stuff because it is a high oxygen area. The patients will typically be intubated, and that tube and the oxygen source and everything are right there where you're working. So you don't want to add in the alcohol as well. And now you've got two fuel sources and two ignition sources for a potential fire. Post-auricular incision. Oh, yes, betadine cannot get into the ear canal. Betadine is toxic to the eardrum. It'll degrade the eardrum. You'll lose your hearing. Not good. Not good. So what they typically do before they prep is they're going to put a cotton ball in the eardrum just in case any betadine gets there. The cotton ball will soak it up before it gets into the eardrum. Yes, there we go. This here is an example of an ear speculum. You guys are going to see this in the myringotomy set tomorrow. But this is, kind of focuses their vision on just the eardrum, and then allows for insertion and removal of, debris and instruments without accidentally scraping the inside of the ear canal and things like that. Some of these too, you can, they have a place where you can hook up a little light cable and then plug that into a light box, and then it can shine some light down into the ear canal too. But mainly, if you're using one of these speculums and you're going through the ear canal, you're going to be using the microscope. So they'll be looking down a microscope into the speculum at the eardrum itself. You're going to have, your typical Raytech on your field. Most often you won't have lap sponges unless you're doing a really big radical neck dissection, where you're going to really dissect out a lot of the structures of the neck. Those are typically for cancer. They take anywhere from like 4 to 8 hours to do, depending on how invasive and stuff the cancer is. There's a lot of nerves and blood vessels and things that they have to very meticulously free up that cancer from, and those kinds of things. So that's why those cases usually take a good while. You may also have cottonoids. The cottonoids typically are used for nasal surgeries. They're these long, skinny sponges that have a long string sticking off of them. The other sponges you're going to encounter are your tonsil sponges. So those are like big balls, balled up sponges that have a string, like a blue string hanging off of them. And they have the little X-ray detectable strip in them and everything too, but they're used specifically to do tonsil surgery with, tonsillectomies. For these, there's no instrument count because we're never entering into a cavity. Right? We may be entering like the nasal cavity, but nothing that is so big and deep that we're going to lose something in it. So we still do our sharps and sponge count, but that's about it. Mastoid and the Glasscock dressings, these are the dressings that are going to be used when you have like major ear surgery, where they have to make that post-auricular incision and work on either the middle or inner ear or something like that. It looks like, if anyone can kind of remember Greco-Roman wrestlers, like the old Olympic wrestlers, they have to wear those headgear things. And it's the things that covers their ear and protects kind of that outer ear. It looks just like that. You have a bunch of the whole package. You'll see it tomorrow, but the whole package has got like a bunch of different gauze sponges and everything to cover over the incision site, and then it's got this big white bowl with straps that cover the ear, and then you strap it to the patient's head, and that's the dressing. So let's talk about a few procedures regarding the ear. We have a myringoplasty. This is to take care of a perforated eardrum. You may use like a little paper patch. It's going to come from like a manufacturer, all sterile, and you just open up it. And usually those patches are going to be bigger than any hole, and you just cut it to the size that you need, and then you go and you can just fit it over that hole. And they're designed to like stick there, so you don't have to suture it in place or anything like that. It'd be extremely difficult to get in there with a needle holder and a suture and stuff and be able to work in that super small space. So it'll just kind of stick over to it and hold. You can also take a little piece of fat and put it down there and just plug the hole, because the tympanic membrane will eventually grow and fix and be kind of not back to original, but as close to as it you can get. Also, the same approach done for like myringotomies. A myringotomy is to treat that swimmer's ear, that otitis media, the infection in the middle ear. You're trying to get that fluid to drain. So you're purposely going to go in and make a little hole, and then you're going to put a tube in there. That's like a grommet. So it's fat on both ends. It kind of looks, when I first saw it, it reminded me of the pipes in Super Mario Brothers. That you go down, right, down into the next level or whatever. That's what it looks like on both ends, how it kind of flanges out up at the top. And that middle part is what sits in the hole, and the two flanges are what kind of hold it in place. But that, again, allows for that pressure relief. That's why they're called PE tubes, or pressure equalizing tubes, because that's what's causing the pain, is that the pressure on the back side of it. Then you can do a tympanoplasty. So that's a little different than a myringoplasty. Myringo and tympano are both referring to the tympanic membrane. But the difference here is, in a tympanoplasty, you're completely repairing the entire eardrum. A myringoplasty, you're just repairing the hole. So it's like with the cloisteoma, right? You have a little growth or a stone or something that's forming in the eardrum itself. You have to go in, and because of the hole you're cutting is so big, there's no patching it. And this is also kind of sclerotic here. You can see it's hardened. You can see it's got that thick whiteness to it. So you're going to remove the entire eardrum, and then you're going to take a little piece of cartilage from the mastoid bone, and you're going to flatten it out real flat and thin, and then go in and put that in as the new eardrum. So that's the tympanoplasty. A lot of times this is called a mastoid tympanoplasty, because you have to go through the mastoid bone. That's this picture showing here, is that post-auricular incision, and going through the mastoid bone to get access to this area and work. Tympanomastoidectomy, yeah. And these are some of the reasons behind it, right? There's something wrong with that eardrum. Right? It's either got something growing in it, or something's happened to the canal wall itself. Right? It's strictured off, or something like that. You're going in to repair that, but you're going through the mastoid bone. That's why it's called a mastoidectomy, because you're burrowing through that bone behind the ear to get access to this area. Non-functioning eustachian tube could be that the tube itself is strictured off, or it never, when you were born and developing and stuff, it was growing from the sinus and it was growing down from the ear, but they just never connected. So it never actually became a full tube. Stapedectomy, or sometimes referred to as an ossicular reconstruction. So this is the image. Let me zoom in on this. From microscope, looking into the ear, into the middle ear, and what you see coming up here, this is the malleus, or the mallet. This is the anvil, and this is the new stirrup. This is that plastic stapes that I was talking about. And see how it plugs right into that oval window. So now you can still get that vibration of sound transferred to the cochlea. And it could be just like, you could have like an osteoporosis or a sclerosis that's hardening this. So it doesn't, and it's not just hardening the stapes, but it's hardening the mallet, it's hardening the anvil or the malleus incus. Right? And with all of these hardening, then they don't flex as well as they used to before. You get maybe some sclerosis or hardening in these ligaments, right? And they just don't move as well as they used to before, and that's going to degrade what's being heard. So you can go in and repair and replace some of these parts to try and get back to a normalcy. Here's that cochlear implant. See what I was talking about before? As they'll drill in the head, this is that little probe or wire thing that goes into the cochlea, so that the sound it gets, it's picking up here from the hearing aid. Slide it this way. So this is picking up the sound that's in the environment, right? And it's sending that sound. So this is your external ear. Which one? The cochlear implant? Let's see, cochlear implant. I'd probably say a couple of hours, because when they're putting this probe in to the head, they're watching all this under like a CT scanner. So because all of this is small, and they're basically kind of doing it blind. So they're watching this wire go into exactly where they need it to, and getting everything set up, and then making sure all this is connected, and then testing and stuff like that. So it may take a little while to make, to get into that space and make sure that everything is connected and correct. But this is acting as your external ear, right? It's picking up that sound. And then this is acting as like your middle ear, where it's transmitting that sound down to the cochlea. And then that's sending that down the wire to the nerve. And that's now taking the place of that external, middle, and inner ear. but typically done on children under 2 years or older. Because anything still up to 2 years, those nerves and those structures and things may still be developing. Depends if, like, they were premature, stuff like that. Yeah, I think what they replace is, obviously, pardon me, the hearing aid and the external components can get replaced. As far as like the wire, it may depend on like the growth of the patient, how often it needs to be replaced, things like that. But they're machine parts, so they are going to wear out. So it may, over the course of a lifetime, you may have to replace it. Uh, maybe like a dozen times, or it could be less than that. But it's something that you have to live with definitely for the rest of your life. Let's see, making sure I got everybody who's here for attendance. I'll double check it with the master list. Let's see that one. Yep. Does anybody have any questions? We're gonna pause here on the. That's it for the ear. When we get back, we're gonna talk about the throat and the nose on Wednesday. Little PSA, EALs, guys. There's I think 3 or 4 of you that I'm specifically talking to right now. The rest of you who know that your EALs are good to go, you can not pay attention to this part, but grades are starting to run dangerously low on those who need to work on their EALs. Taking 0s and 5s and 7s on these EALs is not going to help you at all. You need to start working on your time managements. By now, these weeks, you should have kind of dialed in. Okay, Monday, I do this little bit. Tuesday, I do that little bit. Wednesday, I do this. Thursday, I do that. And by Friday, I've got everything turned in. It's the same thing. I think there's a few of you that I'm talking to about discussion boards. I know discussion board doesn't seem like it's worth a lot. It's 10% of your grade. If you don't do discussion boards, you're already starting at the best you can get is a 90. EALs are 20% of your grade. If you're not doing them, the best you can get in the class is an 80. Remember, you need a 75 to pass. That only leaves you a 5% error margin on finals and quizzes and your homework. And there's a lot of useful information sometimes in those EALs, things that are not on the PowerPoint that you see on a quiz somewhere. For those of you who have been handling your business, I appreciate you. I thank you. Your grades obviously reflected. You can see that.
Thank you. I appreciate
it. You're welcome, Marcellus. You got to work on those time management, guys. You got to get it dialed in, locked in. That way, next term is a piece of cake. You already know what days you're working on doing what. Marcellus the double goat, huh? 2 goats now. As far as the lab goes, Ortiz will disagree with me because he wants you guys to be absolutely perfect. But I can tell you right now in lab, your guys' skills are right on point. Right? I know it can get boring in the lab, just sitting around, waiting for somebody else to go or trying to find work to make yourself busy. Uh, review anatomy, quiz each other on anatomy. And it doesn't even have to be the anatomy we're going over. It could be anatomy that's coming up. It could be anatomy that we've already talked about, just to make sure that you're dialed in, you know what's going on, right? That if Ortiz comes in and starts asking crazy questions, that you can answer those questions with confidence, right? Start making up questions that you think Ortiz is gonna ask, and start asking each other. And that way, when he walks in, he'd be like, "Hey, we just talked about that 5 minutes ago. I got that on lock already." Right? He's going to come in, and it's his job to keep you guys on your toes, to keep you, thinking. Oh, wait. And then we can get into maybe some more complex kind of thinking, more critical type thinking, be able to connect some more dots and things like that. Just make sure you guys are reviewing your stuff, staying on top of your assignments, your discussion boards, your EALs. I fully expect to see all 19 of you in Miss Kimbleton's class. I expect to see all 19 of you at clinicals together. I expect to see all 19 of you get your pins together. That's what I want to see. I know you want to be standing there with me. I know you want to hear all the jokes that go out to your fellow classmates. All the shoes, right? She's not on here anymore, but those who are and know, they're probably laughing real hard right now. You want to see Mr. Logan pull out his strong hand for Group C. Right? Group B, I don't know yet. I don't think we have really a thing yet, right? We'll work on something. We'll get something done this term. Get some jokes out there. Right? We got Joyce is getting a pin, even though she's only ever come to lecture. I've never seen her in lab. I've tried, Marcellus. We'll get something. I'm sure that there'll be a Marcellus Wallace comment at some point. He does not look like a bee, in case anyone was wondering. But like I said, all of you together for the rest of the time. We ain't losing another person. And we do that by, helping each other too in the lab. You see somebody who's maybe not quite getting it, not quite understanding, and I'm over working on something else or whatever, you can jump in and work with them. Hey, where do you feel like you're the weakest? Let's go work on that. Because all that's going to do is strengthen your understanding, your skill. Some of the best ways to really understand something is to teach it to somebody else. Find somebody at home. I know that not everybody's got somebody at home. I know not everybody's got somebody at home that's even interested in what you're doing. And in those times, find somebody in lab to really bounce stuff off of. See if you can explain it in a way that they can understand it. Right? You don't have to use like all the same words I'm using or anything like that. If you can get your message across and explain as to the track of blood flow through the heart or the track of stool through the intestines or things like that, then you have now a better understanding of it. And if you can teach it to somebody, then you have it for life. Climb on down off the soapbox. Sorry. Anybody got any questions, comments, concerns? If you need extra time, extra help, Fridays are always open. come, or if you need to, come catch me after lab and say, hey, I'm really not understanding this part or whatever. And if you're group B or C, then, we can work on your thing in the next lab session. Right? Or if there's something when you first walk in that you really, really want to work on, come, grab me, say, hey, I really want to work on this today. And either I can come and help you, or I can find one of your fellow classmates who really has it to come over and help you. And then you guys can work together. So remember, you're in charge of your own education. Sorry, I thought I got down off of that. That's my fault. All right. Any questions? I mean, I know this sounds like great session kind of stuff or whatever. I also want to let you guys know that I am extremely proud of where all of you are right now. All of you have come a long way and have made it to a point where I'm fairly confident in each one of you. But I don't want you guys to take that as a let's rest. Oh, we've got this now. Let's take this as a let's get 10 times better before we go to clinical. Let's really show these people out there the type of class they've got in front of them now. All right. We'll go ahead and end on that.